Hey everyone, welcome back, or if you're just joining us, welcome to KSSP Podcast. I'm Spencer.
I'm Katie. Today we're going to be discussing amphetamines and methamphetamines in this episode. So first, let's look at the brain areas affected by methamphetamine neurotoxicity from the Psychiatric Times. So as we can see here in the frontal cortex and the hippocampus, there is cell death. And then in the striatum, there is cell death and damage to the dopamine nerve terminals. So the common routes of administration for methamphetamine include oral, smoking, hot railing, or injection, which hot railing is you basically are inhaling vapor through your nose. And amphetamines are commonly taken either orally or by snorting them. And then we have the amphetamine image here of how amphetamines interact with the brain. So number one, we have the amphetamine neurochemistry. Then we've got the dopamine and the amphetamine here. So the dopamine storage vessel, the dopamine transporter reuptake, and then the dopamine receptors are down here, and then we've got the postsynaptic terminal. I'm not sure. I don't see the amphetamine in the chart here. I just see it listed in the key, but that's okay. And so there's that image. And then we have the effect on dopaminergic pathways and key to neuroanatomical regions. So in red, we've got the mesolimbic pathway, this red line. Then this green line is the mesocortical pathway. And then this blue is the nigrostriatal pathway. So there's increased extracellular DA targets, cortical and subcortical regions involved in visuomotor control. So I think that's hand-eye coordination. And then we have DA dysregulation alters information processing capabilities, so top-down control, via deficits in collecting, maintaining, and updating of visual information. And then reduced top-down control affects attentional regulation of visual information. So the next we have the altered visuomotor control. It can decrease saccadic latency or velocity, accuracy of SPEM, and continuous visual tracking. And then we have the implication for neurobehavior. So stereotype rigidity in scanning behavior or tunnel vision, less efficient processing of the visual environment, and impaired performance during complex visually guided tasks of high cognitive load, like driving. And I'm assuming this is on the neurotypical brain. For the neurobehavior. And because otherwise, why would they give out the medication to people who have like ADHD?
Yeah.
You know what I mean? Like,
yeah. I mean, unless you take like too high of a dose, then you'll.
That's true too. Yeah, if you do take, like, if you're abusing it, then that's different.
Yes. Yeah.
If you're like taking it medicinally and recreationally are two different things.
Yeah.
So we've got that.
Okay. And then we'll go and just into the pharmacology. So we're going to just start with methamphetamine, and that is a potent full agonist of traceamine-associated receptor 1, or TAAR1, which is a G protein coupled receptor that regulates brain catecholamine systems. Activation of TAAR1 increases cyclic adenosine monophosphate, or CAMP, production and either completely inhibits or reverses the transport direction of the dopamine transporter, norepinephrine transporter, and serotonin transporter. triggers transporter phosphorylation via protein kinase A or PKA and protein kinase C or PKC signaling, ultimately resulting in the internalization or reverse function of monoamine transporters. It increases intracellular calcium producing dopamine efflux. TAR1 has been shown to reduce the firing rate of neurons through direct activation of G protein coupled inwardly rectifying potassium channels. TAR1 activation by methamphetamine and astrocytes appears to negatively modulate the membrane expression and function of EAAT2, which is a type of glutamate transporter. It inhibits synaptic vesicle function by inhibiting VMAT2, which prevents monoamine uptake into the vesicles and promotes their release. The outflow of monoamines from synaptic vesicles into the cytosol, or intracellular fluid, of the presynaptic neuron and their subsequent release into the synaptic cleft by the phosphorylated transporters. And then agonists of the alpha-2 adrenergic receptors and sigma receptors with a greater affinity for...
I think it's omega. I'm not sure.
Is it omega or sigma?
It might be sigma, actually, yeah. I was just thinking that too.
Just because it's talking about like the sigma receptors. So I assume it's sigma. So like for sigma 1, then sigma 2. So greater affinity for sigma 1 than sigma 2. And inhibits monoamine oxidase A and monoamine oxidase B. Sigma receptor activation by methamphetamine may facilitate its central nervous system stimulant effects and promote neurotoxicity within the brain. Dextromethamphetamine is a stronger psychostimulant, but levomethamphetamine has stronger peripheral effects, a longer half-life, and longer perceived effects among addicts. At high doses, both enantiomers of methamphetamine can induce similar stereotypy and methamphetamine psychosis, but levomethamphetamine has shorter psychodynamic effects. And then we're going to move on to the pharmacology of amphetamines. And we're going to, I think Adderall is the main one. So, or there's probably others, but we're just going to. So, amphetamine, the active ingredient of Adderall, works primarily by increasing the activity of the neurotransmitters dopamine and norepinephrine in the brain. It also triggers the release of several other hormones, for example, epinephrine, and neurotransmitters like serotonin and histamine, as well as the synthesis of certain neuropeptides, cocaine and amphetamine regulated transcript CART peptides. So, both active ingredients of Adderall, dextroamphetamine and levoamphetamine, bind to the same biological targets, but their binding affinities differ somewhat. Dextroamphetamine and levoamphetamine are both potent full agonists of trace amine associated receptor 1, or TAR1 again, and interact with vesicular monoamine transporter 2, VMAT2, with dextroamphetamine being the more potent agonist of TAR1. Consequently, dextroamphetamine produces more CNS stimulation than levoamphetamine. However, levoamphetamine has slightly greater cardiovascular and peripheral effects. In the absence of amphetamine, VMAT2 will normally move monoamines, example dopamine, histamine, serotonin, norepinephrine, etc., from the intracellular fluid of a monoamine neuron into its synaptic vesicles, which store neurotransmitters for later release via exocytosis into the synaptic cleft. When amphetamine enters a neuron and interacts with VMAT2, the transporter reverses its direction of transport, thereby releasing stored monoamines inside synaptic vesicles back into the neuron's intracellular fluid. Meanwhile, when amphetamine activates TAR1, the receptor causes the neuron's cell membrane-bound monoamine transporters, so the dopamine transporter, norepinephrine transporter, or serotonin transporter, to either stop transporting monoamines altogether or transport monoamines out of the neuron, In other words, the reverse membrane transporter will push dopamine, norepinephrine, and serotonin out of the neuron's intracellular fluid and into the synaptic cleft. So, in summary, by interacting with both VMAT2 and TAR1, amphetamine releases neurotransmitters from synaptic vesicles into the intracellular fluid, where they subsequently exit the neuron through the membrane-bound reversed monoamine transporters. And then we're just going to briefly also mention lisdexamfetamine. And lisdexamfetamine is an inactive prodrug that is converted in the body to dextroamphetamine, a pharmacologically active compound that is responsible for the drug's activity. And another name for this one is Vyvanse. So, after oral ingestion, lisdexamfetamine is broken down by enzymes in red blood cells to form L-lysine, a naturally occurring essential amino acid, and dextroamphetamine. The conversion of lisdexamfetamine to dextroamphetamine is not affected by gastrointestinal pH and is unlikely to be affected by alteration in normal gastrointestinal transit times. The optical isomers of amphetamine, for example, dextroamphetamine and levoamphetamine, are TAR1 agonists and vesicular monoamine transporter 2 inhibitors that can enter monoamine neurons. This allows them to release monoamine neurotransmitters from their storage sites in the presynaptic neuron, as well as prevent the reuptake. So basically then, once it gets converted to the dextroamphetamine, it does the same as Adderall then. And lisdexamfetamine was developed with the goal of providing a long duration of effect that is consistent throughout the day with reduced potential for abuse. The attachment of the amino acid lysine slows down the relative amount of dextroamphetamine available to the bloodstream. Because no free dextroamphetamine is present in lisdexamfetamine capsules, dextroamphetamine does not become available through mechanical manipulation, such as crushing or simple extraction. A relatively sophisticated biochemical process is needed to produce dextroamphetamine from lisdexamfetamine, as opposed to Adderall, which contains roughly equal parts of racemic amphetamine and dextroamphetamine salts. Lisdexamfetamine is a single enantiomer for dextroamphetamine formula. And then, I guess, studies conducted do show that lisdexamfetamine dimesylate may have less abuse potential than dextroamphetamine and an abuse profile similar to diethylpropion at dosages that are FDA approved for treatment of ADHD, but still has high abuse potential when this dosage is exceeded by over 100%.
Yeah, I don't know. I mean, I'm just gonna say with like it, I really don't see it having less abuse potential. There's, I don't know, people still abuse it a lot. I mean, and that doesn't mean people shouldn't use it medically, but like a lot of people just use it recreationally, just like they would with Adderall. And I mean, they
I
can't
mean, it
snort
still
it necessarily.
causes the same effects. It's just the main thing is like you can't snort lisdexamfetamine. Like it
Right.
isn't going to activate as quickly as Adderall would. So people are more likely to abuse Adderall if they're trying to get like a quick high, because lisdexamfetamine is going to take time because it has to do that conversion to the
Yeah,
active molecule. It doesn't mean that it can't be abused, obviously, but
right.
I think so in their theory, because it takes longer, it is gonna be less likely to be abused. But yes, it is still obviously abused because it
I
does
mean,
cause like the
I
dopamine
guess,
effect.
I guess when they say less likely to be abused, like I guess if you think of it in the scenario where you can pick between one or the other, people would probably pick the Adderall over the Vyvanse if they're trying to use it recreationally. But like, I mean, yeah, I don't know. It's still, I mean, and they do say there is still high abuse potential.
Yeah,
But yeah, I just wanted to point that out. I don't know. I just felt the need to point that out.
yeah.
That, that does happen quite a bit. But anyways, so we're going to go over the side effects of meth specifically, and some of these side effects, most of them would also they can apply to amphetamines as well, especially taken at high doses. So yeah, initial side effects include rapid heart rate, and this is from American Addiction Centers. So side effects, rapid heart rate, increased blood pressure, anxiety, insomnia, increased respiratory rate, elevated body temperature, paranoia, aggression and violence, convulsions, tremors, death, or cardiovascular issues such as stroke and heart attack. And then there's other adverse long-term effects of chronic methamphetamine use, or even chronic amphetamine use in, high doses, or for people who don't need it medically. And they may include stimulant addiction development, changes in the brain structure and function, decreased motor skills, verbal learning declines, chronic anxiety. Then we've got repetitive movements, visual and auditory hallucinations, delusions, paranoia, chronic anxiety, aggressive or violent behaviors, mood disturbances, and then memory loss, malnutrition, and severe dental problems. And individuals who abruptly stop taking crystal meth after long-term use. We'll talk about a little more of these symptoms, but in another episode. But if you stop after long-term use, withdrawal symptoms may include fatigue, depression, anxiety, and drug cravings, and more. And so that's our little episode on amphetamines and methamphetamines. So join us next time. We're going to be talking about opioids and opiates.
And as always, you can leave a comment below if you have ideas for topics that you want to hear us talk about in future episodes.
You can reach out to us on Facebook, Instagram, YouTube, Twitter, and TikTok, and we occasionally Twitch live stream as well, so follow us there to be notified when we do.
And don't forget to give this video a like, as well as follow or subscribe to our other social media accounts and turn on notifications so that you get notified when our future content comes out. Otherwise, we will see everyone in the next video.